Hello, my name's Abbie and I'm a third year at the University of Warwick, and today I'm going to talk about Parkinson's. So, let's get started. Let's say you're working as an FY1 in a neuro department of a hospital. You're invited to the Parkinson's assessment clinic. You meet Brian. Brian is a 70-year-old gentleman who presents with a history of fidgeting and stiffness. So he's obviously been referred to the hospital because the GP assumes that he may have Parkinson's. But what exactly is Parkinson's? Well, let's draw it out and talk about it. This is a very rushed out basal ganglia, but it will work for what we need. Essentially, Parkinson's, if you need to write it out in an exam, is the loss of dopaminergic neurons from the substantia nigra. But what does this mean in practice? Well, this is our basal ganglia. I won't talk through how it works because I haven't got time for it in this video. But what we do is we essentially lose the dopaminergic neurons here. If we think about a brain slice, it's that patch of very dark or black neurons near the bottom of the brain slice in a coronal view. So what happens? Why do we care if dopamine is gone? Well, if these neurons go, it means there's no dopamine reaching a striatum. This means the striatum no longer inhibits the globus pallidus, because you've got nothing telling the striatum to basically do its job. So the striatum will not continue to send out these signals. This means the globus pallidus internus is essentially free to do what it wants. In fact, it's got this excitatory input coming from the subthalamic nucleus. So it sends out these inhibitory inputs into the thalamus as it pleases. What does this mean though? It means the thalamus no longer sends excitatory inputs to the motor cortex, or it does significantly less than it used to. This means that the motor cortex basically doesn't get told to fire, and we don't get told to move. Hence why the classic symptom with Parkinson's is slow, stiff movement. How can we diagnose Parkinson's now that we know what it is? Well, to be diagnosed with Parkinson's, you tend to have to show symptoms rather than being a definitive test. The first big one is bradykinesia, or this slow movement, which we know is because the motor cortex is not receiving as much excitatory input. This bradykinesia will then slow the patient's movement, and this is responsible for a shuffling gait often seen in Parkinson's patients. The patient must have one or more of the three following symptoms as well as the bradykinesia to definitely be diagnosed. The first one is muscle stiffness, and we quite often associate this with cogwheel effect on examination. So as well as the patient's movements being slow, there's the tremor kind of inputted on top of that. The biggie and the big giveaway is a unilateral resting tremor. If you're savvy and can remember it's at 4 to 6 hertz, then go ahead. But the big thing to remember is that it's unilateral and only at rest. A common exam question is to try and get you to differentiate between a benign resting tremor and a Parkinson's resting tremor. The clues in the spelling: benign, bilateral. And then finally, postural instability. A good way to test this is to have the patient stand in front of you, for you to come around the back, obviously explain what you're doing before you do this because it can come as a bit of a shock, and gently pull the patient back by their shoulders. A normal reaction is a couple steps backwards to try and regain their balance. If you find though that they're really travelling back across the room and that you're having to step in to hold them, then this is a sure sign that your patient may have postural instability. As well as these key symptoms, there are often other symptoms associated with Parkinson's that are not motor symptoms. These are loss of sense of smell, obviously at the moment, differentiate this by doing a COVID test. Depression and psychosis, so this is when they'll often be hallucinating small animals such as spiders. And impulse control disorders, again a key disorder to pick up on especially early, but we'll talk more about this later. They may often have excessive daytime sleepiness and REM sleep disturbance, urgency and constipation, and orthostatic hypertension. This is a lot for one patient to handle. So how can we go about treating Parkinson's? So Parkinson's is something that you want to treat holistically. But first, let's focus on the movement. The first big drug to give, and his first line, is Levodopa. This is synthetic dopamine that can be administered, and a common exam question, especially in the earlier years, is why can't we give dopamine in its pure form? Why? Because pure dopamine, ironically, can't cross the blood-brain barrier. So we have to give dopamine in a synthetic form that can, hence Levodopa. This essentially replaces the lost dopamine that we lose from the dopaminergic neurons in the basal ganglia. Now, Levodopa isn't often given as the only drug. It's given combined with another drug, so you won't often see Levodopa on a patient's drug chart. What we will see is cocarodopa and cobeneldopa. That is really poor pronunciation, but I will put them on the screen so you can see. These are peripheral decarboxylase inhibitors, or COMT inhibitors, COMT, and are often given in combination because they stop levodopa being broken down in the periphery. Speaking of dopamine, we can give dopamine agonists, and these work by essentially binding to receptors on the postsynaptic neuron and exhibiting the effects that dopamine used to give. Common examples of dopamine antagonists are pramipexole and ropinirole. Again, I will write these here. And finally, we have our monoamine oxidase B inhibitors. These prevent the enzyme in the brain from breaking down any dopamine that is already there. Common drugs for this is razagiline and celandine. Now that we have successfully diagnosed Brian with Parkinson's disorder, we've sent him off with cocarodopa. We call him up a few weeks later to check how he's getting on, and he reports he's almost feeling back to normal. You smile, because a 70% improvement in patient symptoms is also a key diagnosis point for Parkinson's. However, a few weeks later, Brian's wife, Joan, appears at the GP surgery. She looks exhausted and is close to tears. And you ask her what's wrong. She tells the GP that Brian has been waking up in the middle of the night. He's shouting at something that isn't there and often thrashes about. This has been going on for a couple of weeks. But last night, Brian accidentally hit her around the face. Brian was asleep at this time and wasn't aware it was going on. Joan is exhausted, and last night's events were the last straw. She said she's not told Brian because she knows it's not his fault and he can't do anything to help it. She wonders if you can give her something for sleep, just so she can get a good night's sleep for once. You say you can, but maybe we can fix the problem at its root. Excessive REM sleep disorders are quite common in Parkinson's, but they're easily treatable. The first step is sleep hygiene and working with the patient to figure out good routines of sleep. If this doesn't work, however, there are pharmacological treatment. The treatment is melatonin, but it's wise to get a full sleep profile and full background before you give this, as this can result in excessive daytime sleepiness, which ironically is also another symptom of Parkinson's. So you can either give Brian melatonin to sort out the night problems, or if he's feeling extra tired during the day, modafinil, often known as the trolley dog, can also help. However, this is where a DVLA comes in. So when a patient is diagnosed with Parkinson's, you need to warn them that they should let the DVLA know, but ultimately the DVLA will decide if they can drive or not. Impulse control disorders are common, and these do need to be picked up early. If we say that pathophysiology behind Parkinson's is disruption of one dopamine network or pathway in the brain, then it's more than likely that other dopamine pathways are also going to be affected, and we all know dopamine is highly implemented in reward-based behaviour. Impulse control disorders are common manifestations in Parkinson's. We know Parkinson's is disruption to one of the dopamine pathways in the brain, the movement pathway. However, we all know dopamine is implemented in the reward pathway. So if it's going wrong in one pathway, it's more than likely to be going wrong in another. These disorders are imperative to pick up early, as they can lead to huge problems down the line. There have been history of Parkinson's patients gambling away life savings. Parkinson's can also cause hallucinations, as we said. These can either be a result of Parkinson's itself or, again, the medication. It's important to get a good history around this, as sometimes patients can put up with hallucinations. We can give common medications such as quetiapine. If quetiapine doesn't work, then clozapine is the second line. Again, make sure it's not to do with any of the original medications. Orthostatic hypertension is also a really common symptom of Parkinson's. Again, it's checking the medications aren't causing the problem. If they're not, dietitians can help by increasing water intake and sodium in the patient's diet. If all that fails, midodrine, as seen here, can be given as a means of controlling the blood pressure. It is so important to take holistic care in Parkinson's patients overall. It's a disease that not only affects the patient but can affect the wider family. It's often their partners who end up caring, and due to the advanced age that this disease presents, it can be a lot of burden for these patients and their families. There is a large MDT network working with each patient, so it's important that there is good communication between the team and that the patient feels adequately supported. We're nearly coming to the end, and one big thing that I want to mention is neuroleptic malignant syndrome. This arises from a patient suddenly stopping their Parkinson's medication or a dopamine antagonist being introduced. Patients present with tachycardia, high blood pressure, sweating, nausea, hallucinations, fluctuations in GCS and kidney damage. It is a medical emergency. The way you treat this is to give back their Parkinson's medications, take control of their blood pressure and monitor their kidney function. Parkinson's treatment is evolving all the time, and we now have deep brain stimulation, which is 2 rods inserted into the brain, which can change patients' lives for the better. A quite severe tremor can be simply switched off, all by a couple of rods in the brain and a pack, or similar to a pacemaker pack, just on top of their chest. Parkinson's is such a wide and varied disease, and it's something that does dramatically affect patients. However, with the right support, early treatment and a good MDT team, there's no reason why these patients can't go on living a good life for as long as they possibly can. Thank you very much for watching. I hope this has helped, and just to let you know, Brian is doing extremely well and his wife is having a good amount of sleep. Thank you.